Good morning, I'm Jessica Lovell, and today we bring you an encore presentation of one of our very favorite programs. This one focuses on a huge chain of kidney donations involving 24 people. There are currently more than 100,000 people waiting for a kidney in the United States. Right now, our team is working hard behind the scenes to bring you more amazing stories when our live programming returns in September. However, if there is an urgent update from the health system, we'll be here to let you know first. Until then, though, enjoy this encore presentation and make it a great day. Coming up today, behind the wheel at last. Meet a woman who wasn't allowed in the driver's seat until she finally found a solution to her seizures. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Uncontrolled epilepsy puts limits on patients' lives. If you don't know when the next seizure could strike, it can be hard to stay in school or even hold down a job. And it's often too dangerous to drive until you prove you're seizure-free. Today, we are meeting a young woman and mom who is finally hitting the road thanks to a brain implant. For most young people, getting to drive is a rite of passage, except for Mallory Contreras.
It kind of sucked when all my friends were learning how to drive and getting new cars. Couldn't do that.
Mallory, now 30, says getting to drive means so much more now.
Having to always count on somebody just to go to the store or something, having to call somebody to get a ride. And now, being able to sit in the car and drive, it feels really good.
Mallory's barrier to driving started with a headache back in elementary school.
I had a really bad migraine when I woke up, and being that young, I didn't know that's what it was, just thought a bad headache. Took some medicine and went to school.
Things got worse from there.
I remember getting sick and then just waking up in an ambulance with my mom.
Later at the hospital, Mallory and her family learned that she had had several seizures at school. It was then doctors officially diagnosed her with epilepsy.
It was kind of hard because I realized I couldn't do sports and do most things kids my age were doing because it would cause a seizure to happen. I couldn't drive when all my friends were learning how to drive, but luckily I had a brother that's only about a year and a half age difference, so he took me everywhere.
After years of MRIs, medications, and searching for treatment options, Mallory found answers at the University of Kansas Health System.
And that's where they decided I was able to do the RNS device.
A responsive neurostimulation system that's implanted into the brain and is programmed to monitor a person's seizure patterns and automatically responds to prevent them.
They implanted it under my skull here on the left side on my brain, and it has the leads that go on each side. And it kind of monitors my seizures. It took them a while to figure out the sweet spot to help it zap the seizures when they start and stop them. We're kind of at the point now where I'm not having any at all.
From having several seizures a week, Mallory is now 6 months seizure-free, which means she has been legally cleared to get her license.
I've never had a license before or anything, so I've been practicing for a while with my mom.
And the device has given her far more than that. It's given her quality time with her 6-year-old daughter.
Just being able to, taking her to school and stuff, it'll be nice when I can drive. I can do it by myself. I'll be able to cook more for her and do more things without having to rely on other people so much. Show her that we can, start doing things normally like other people.
And Mallory is here in studio with us alongside her epileptologist, Dr. Utku Usal. He is one of several experts working in our Comprehensive Epilepsy Center here at the University of Kansas Health System. Good morning to both of you.
Good morning.
Good to have you both reunited. When's the last time you all saw each other?
A couple of months ago.
Okay, good, good. Dr. Usal, it must be great just seeing a patient start to really gain that independence, right?
Yes, that's great. This is actually the outcome that we are all hoping for. And personally, for me, there is nothing more satisfactory professionally to see a patient being seizure-free and gaining their independence.
And Mallory, this video that we're seeing of you driving truly is the first time you've been behind the wheel.
Yes, it is. Yes.
Ever in your life. So you're practicing. When do you actually get your license? This is like a learner's permit. When will you officially be on the road?
Well, I don't. learners permit. We're just practicing right now. I don't really have one of those. I want to make sure everything is okay with Dr. Uwesal before we drive. And I'm still a little nervous driving because I haven't done it in here. I'm 30 years old. So.
Well, I would imagine. I mean, that would be, it's a rite of passage that people get to do when they're 15 years old, and here you are doing it, stepping into the lane when you're 30. I would imagine that would be so kind of scary, right?
Yeah, a little bit.
When's the last time you had a seizure?
I haven't actually felt a big one, and maybe a year and a half, 2 years. It's been a while, but I have ones that Dr. Uwesal can see, and that's been about a year.
Your first seizure, though, was back in the 5th grade?
Yes.
Back in elementary school. And from then on in school, you mentioned that you had a lot of support from your family. Your younger brother, we mentioned, helped you out a lot. They really understood what epilepsy was doing to you. But how did you explain it to other people around you? I mean, this is something that you're dealing with at such a young age. How were you explaining it to people? That must have been tough.
Yeah, it was kind of hard because also I didn't know very much about it. I'm kind of learning along the way at that time. But things that the doctors would tell us, I would try to explain to friends at school or people at school, but everybody was just kind of freaked out about it. And I guess everybody's different when they have their seizures, but having my family there was it was good. They were a lot of support to help me. So if people did see one, they can kind of explain or.
How intense were they?
Mine were, they were grand mal seizures, so it sounds like it's one of the worst ones you could have, where I get a little bit of a warning sign, and then before I know it, I'm waking up from it. My mom said, yeah, you fall down sometimes, or you shake on the floor, things that you kind of like see on TV.
So you found out that these seizures were coming from a certain part of your brain. Dr. Uwesal, what part of the brain are we talking about with these types?
Well, based on Mallory's seizure symptoms, and the testing that we have done, we were able to localize her seizures to a temporal lobe on both sides. Unfortunately, her seizures were coming from both temporal lobes, particularly an area that's called hippocampus, which is deep and towards midline in the brain.
So if a seizure starts there, what symptoms would arise?
The symptoms from temporal lobe seizures can be various, and people may have different type of seizure symptoms, but most commonly they can experience a small symptoms where they don't lose their awareness, and they consider this as a warning sign or their aura. And this could again be a bad smell, metallic taste, sudden unexpected feeling of anxiety or fear. It could be a forced thinking, deja vu. So a variety of different symptoms can happen. And at that point, the seizure itself may stop or may progress into more complex presentation. Or it can start with more complex presentations, such as loss of awareness, staring off, behavioral arrest, some stereotypical semi-purposeful movements that we call as automatism, such as lip smacking, repetitive swallowing, some fidgeting in the hands, at the feet, finger tapping, buttoning and unbuttoning type of movements. And also people may lose their speech or inability to comprehend, are not able to comprehend. And again, at that point, the seizure may stop, and the patient may feel a little bit confused postictally after the seizure and regain their baseline status, or the seizure may evolve into a full-blown convulsion.
So a variety of different
different symptoms.
Yeah.
Yes.
Do you remember some of the triggers?
I would get a really bad migraine, and a lot of times if I didn't get the migraine under control, it would turn into a seizure.
So you would feel that coming on, and you would know that that was what? Did you feel a lot of these symptoms, though?
Oh, yeah, a lot of them that he said. I know that, like he said, the deja vu feeling, or my parents would know it was coming on if I would swallow a lot or kind of stare off, or when I would talk, I would think I was saying something and they couldn't understand. So then we know, okay, seizure's coming.
Something's coming. Dr. Uwesal, could you define epilepsy for us?
Well, epilepsy is defined by the International League Against Epilepsy as a brain disorder characterized by enduring predisposition to generate epileptic seizures. But we also have a practical definition of epilepsy. When patients meet certain conditions, then we can diagnose them with epilepsy. Number one is two seizures, at least two seizures that are at least 24 hours apart each other. And the seizures must be unprovoked, meaning that there should not be any transient cause that cause the brain have a seizure as a reaction. Such as an example, if someone has a dangerously high level of blood glucose, this can put brain under stress and generate a seizure. But if that person's blood sugar normally runs in and well controlled within normal limits, then the brain does not have that predisposition to generate seizure. So, or somebody who goes through alcohol withdrawal, or who has an acute trauma to their head, they may have a seizure in that occasion just as a reaction to that. But with the epilepsy, the seizures should be unprovoked. There should not be any transient or reason for that brain to have seizure at that point.
Where does epilepsy come from? What causes epilepsy from its roots?
Well, epilepsy can be caused by a variety of different problems. For example, structural brain abnormalities, tumors, stroke, intracranial bleeding, abscess, infection. Some people have metabolic diseases that goes with the epilepsy. Some epilepsies are genetic or caused by autoimmune diseases. Or some people are born with some congenital malformations in the brain that can cause seizures. Or they could have, for example, lack of oxygen during birth can be a cause of seizures. But in a lot of patients, up to 50% of the patients, we cannot find any reason with the current test available to us.
Mallory, do you know what caused yours?
Not really. Honestly, I don't think we ever found, because the only thing that happened was when I was born, there was a little bit of problems but didn't really match up with my epilepsy. But it happened when I was in 5th grade, so we were like, why didn't I have them before if something was wrong?
So it can still remain a mystery, it sounds like, in many cases.
That's true.
I want to talk about this RNS stimulator, and we're so glad that you've remained seizure-free since having this implanted, but it's not a first-line treatment. What are the standard treatments for epilepsy? And can they completely eliminate seizures in some cases?
Well, they can. If somebody is diagnosed with epilepsy first time, the initial treatment is with the anti-seizure drugs. And in about 50% of the patients, they can achieve seizure freedom with the first tried seizure medication. With another 15% can achieve seizure freedom with addition of the second drug or trialing the second drug. Unfortunately, after 2 or more medications have failed, the chance of achieving seizure freedom only with the seizure drug, anti-seizure drugs, is very minimal. And in those cases, we define their epilepsy as drug-resistant epilepsy. But there are certain points important here. The anti-seizure drug that is used should be appropriate for the patient's type of epilepsy and seizure. And they should be tried or used for an appropriate duration at an appropriate dose. So because a patient develops side effects before we can try the drug at an appropriate dose for an appropriate duration, and we have to stop that medication, that doesn't count against drug failure for that particular drug.
Were medications helping before the implant?
I mean, at times, but then not really.
Any side effects?
Well, they can cause you to be drowsy and stuff, but I mean, when they're not really working, then it's kind of hard to, figure out what's next. When you try, I think I tried like 3 different medications throughout my time of this.
How do you identify who is a good candidate for this RNS device?
As I said before, some people do not respond to the medication. So those are the patients that we recommend to be evaluated extensively for a possible surgical treatment option. But particularly RNS system is approved by the FDA in late 2013 for as an add-on treatment for patients who have at least 2 seizure epileptogenic foci that can produce seizures, and still continuing having seizures, disabling seizures, despite being on 2 or more seizure medication. So particularly for those people, RNS system is approved. But we prefer patients first to undergo an extensive evaluation, because based on our testing, we may offer a resective surgery or ablation which can cure their epilepsy. But for some people like Mallory, where the seizure starts from more than one area, or where the seizure focus cannot be resected because it is located in a vital area in the brain, such as motor area or language area or visual area, then neuromodulation methods like RNS system can be beneficial for these patients.
We have an animation from the device maker. Can you explain how the RNS works?
Sure. So as you see, the neurostimulator itself is placed under the scalp, within the skull. And there are 2 electrodes connected to this neurostimulator, and the electrodes can be placed any area in the brain, within the brain, or on the surface of the brain, or as you see here, like a combination of both. And what happens is that the neurostimulator monitors the brain activity with these electrodes, and based on the parameters that we upload to the neurostimulator, it may detect the seizure, and as soon as it detects a seizure, it delivers an electrical pulse to stop the seizure, or before the seizure can progress.
And we have an EEG showing Mallory's brain waves. Where does the stimulator kick into action?
So as you can see on the very left side, that is the Mallory's normal brain activities when she's not having seizure. And on the first 2 channels, so towards midline, as you see, there is sudden increase in the amplitude, and the brain activities becomes more rhythmic, goes into a more rhythmic pattern. And the label A1 shows that the seizure is detected by the system within about a second or so. And then next to it you see the TX that applies to all channels. This is where the device delivers the therapeutic stimulation to stop the seizure.
So how does it calibrate? Does it automatically know the difference between a seizure and a normal brainwave?
It does, based on how we teach them. So when the device is first implanted, we turn the settings on with very generic settings, and we wait for the patient to heal and recover from the surgery. And first time we see them in the clinic, based on the seizures that are captured and recorded by the neurostimulator, we come up with some protection settings that can be applied for that patient's particular seizure type. Based on how the seizures start, what frequency, and how much amplitude difference at the onset of the seizure compared to the baseline, we set the parameters, and we can simulate them on the patient's previously recorded seizure, and then send the patient home, wait for more seizures so that we can fine-tune it the next time, depending on how in real time the parameters that we set performs and does its job.
So Mallory, how did you feel about all this when you heard about this opportunity to have this implant? The idea of brain surgery can be a bit scary.
Yeah, it was a little scary at first, but then after hearing all that it can do and knowing that I had a daughter, I'm thinking this could really be something good that will help me take care of her.
Recovery, how was that like? What was that like?
It wasn't bad. You have your little pains after surgery, but yeah.
How soon after did you notice changes? Did it take time, or did it happen pretty immediately?
It took time. It took a little time. After a few times of when you go to the doctor and everything and they explain it, then you kind of learn more about it, and you can kind of feel, or not feel when it works, but you feel better, I guess. So because the seizure is not full blown.
So when the RNS intercepts a seizure, do you feel anything? What's that sensation?
I don't feel it like in my brain, but like when the seizure is coming, I would go tell my mom, okay, I'm feeling this or feeling that I normally feel before a seizure, and then it would just kind of go away. So I was like, oh, the seizure didn't happen.
Just didn't happen.
Yeah.
That's a nice feeling.
Oh yeah.
Well, if you have any questions about seizures, epilepsy, and treatment options, now is your chance to get them answered by the expert. So drop those questions in the comments in the chat on YouTube or Facebook. You can also email the Medical News Network. Mallory, the last time that we spoke with you here on our program, you had mentioned a seizure cost you a job, even though your boss knew that you had epilepsy. Tell us what happened.
Well, when I had got the job, I had let them know I have epilepsy. This is one of my first jobs, and they said, no, that's okay. We'll put you in an area, where you will have supervision and everything. Things will be good. And I had just in a couple of months working with them, I had 2 or 3 seizures, and they said, okay, this is very scary. We can't help you with this. We have to let you go.
That could be a frustration, Doc. You had mentioned that before the program, that's something that you talk with patients about.
Yes, and this is a very common problem that we hear and unfortunately encounter it all the time with our patients as well. So even though the American Disability Act protects people getting let go just based on their medical condition, unfortunately this is not the case with our epilepsy patients a lot of the time. And I think this is a multifactorial and multifaceted problem. In my mind, some of the reason for that stems from the lack of general population and employers' knowledge about the epilepsy and seizures, and how seizures and epilepsy are perceived and manifest at the work environment. So for the employers, what we hear from the patients, I can say that they consider this as a liability and safety issue at their work environment, and they don't want to employ or they don't want to work with the patients anymore. In addition to that, we ask our patients, of course, follow strictly the seizure precautions and driving restrictions. Definitely, if there is not available public transportation or reliable designated driver, this is very difficult for patients to find an employment. Also, these seizure precautions and the restrictions can be regarded by the employers as an inability of our patients to perform the duties required by their job, and they can use this as an excuse to terminate their employment. Or the patients may be asked to have to apply for short-term or long-term disability, which they may not even have an access to. And applying through for the disability through the Social Security is a long process, and they are not guaranteed to get it. So that means that a lot of multiple months without any income, losing their insurance that they definitely need for their much needed health care and the medications. So this is a big problem, and thanks God in our clinic we have a very amazing and passionate social worker, case manager Leticia Jackson, and also our clinic staff and nurses are very knowledgeable and also very helpful to navigate our patients with through this problem, and also be advocate for them and refer them to the necessary resources if needed.
Thank you for mentioning those resources. There are plenty of misconceptions about epilepsy. Some people think it prevents you from having a family by getting pregnant. Is that true?
No, epilepsy patients can definitely get pregnant and have healthy people. Of course, there are always a concern about birth defects that can be caused by the medications, anti-seizure drugs. And it is more of a concern if a patient has uncontrolled epilepsy and on multiple anti-seizure drugs, but majority of the people definitely can be pregnant and have healthy babies.
People like Mallory, because you have a beautiful daughter, Natalia.
Yes.
Tell us about her and how things are going with you guys.
Things are going great. She's growing up very fast. Getting ready to finish first grade, but things are a lot better now because with the RNS device I don't have to worry about her seeing a seizure or being afraid of things just because we're not what you would call normal, I guess, having to count on other people for things, but being able to show her that we can do those kind of things is nice. Yeah.
I want to get to a couple questions from our viewers this morning. Amy wants to know, how new is the RNS and are there different models?
Actually, there is one current model that we all use, but the RNS, as I mentioned before, RNS system is approved by the FDA in late 2013. So that means, of course, previous studies were completed like feasibility or randomized controlled double-blind study to get that approval. So that tells us that it has been out there since the end of 2000s.
Jeremy wants to know, now that the device is installed, are all the adjustments moving forward about the signal itself, or does Mallory have to have more surgeries in the future?
It is a very good question. So it requires, after the installation of the device, it requires a period where we try to fine-tune and get the optimal settings. And also regarding the further surgery, there's always a possibility, because sometimes, like Mallory, our testing shows that the seizures may be coming from two sides. And because with this device we are able to monitor the brain activity, brainwave activity, and seizures over an extended period of time, over years maybe, sometimes we found that majority of the disabling seizures are coming from one side. And then that can we can use that to our advantage to offer a resective surgery to achieve seizure freedom. Another possibility for surgery is that, of course, the replacement of the battery. So to replace the battery, we have to do a quick surgery where our surgeons take the old battery and replace a new one.
That was my next question, is how it's powered.
Yes, it
so
is.
You replace the battery.
Yes, you place the battery. It is not rechargeable, or unfortunately, or we cannot have a plug-in cable to charge it. So the battery life is about 10 years, and then it needs to be replaced. But we monitor the battery life each time the patient comes to the clinic, and we know ahead before it nears the end of life.
What do you want the big takeaway to be?
Well, the big takeaway for our patients is that, or for any patient out there with epilepsy, please do not hesitate to refer yourself or get a referral to an epilepsy center if you have still ongoing seizures despite anti-seizure medication, so that you can be evaluated more thoroughly and possibly for surgical options or neuromodulation options that can control your seizures better and hopefully give you the seizure freedom and more independent life.
That's what I was going to say, Mallory. We're so glad that you're out on the road and gaining your independence. What's the big takeaway from your story?
Just that I thought this was something that wasn't possible to fix, because I've had it since 2005, and just to never give up on this. This is a very dramatic change in my life, and I'm very grateful for Dr. Uhisal and everyone that has helped me with this.
Well, thank you so much for sharing. Thank you both for being here with us today.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.